You that once you start ventilating a child, there will be areas which probably are not, she shows you some diagrams of how diaphragm moves, and there will be areas which are not now available because they've gone into atelectasis. They are being perfused, so perfusion and ventilation ratio is worsened. So we need to open up those areas, even in a comparatively normal lung. And when the lung is not normal, those kind of areas will be many already because of the pathology. And those areas need to be opened up. When you have to open up by positive pressure, you will give positive pressure during inspiration, during expiration, which means patient's heart will not fill up well. Hemodynamics will go down. Your patient may crash. You have to be ready for that. Volume status will also have to be taken into consideration. I'll bring out these points when I'm talking about this. Okay. This is one of the consensus on ARDS as to how to go about treating these patients. There are two of them published very recently in 2010, and this is what we have come, that if there is a ARDS your diagnosis, go around with lung protective strategies, fluid conservative hemodynamic strategy, not too much fluid. Look at the plateau pressure. If the plateau pressure is less than 30, think of recruitment maneuvers and or high P. If the plateau pressure is more than 30, probably you already lost this area. You may try it, but may not work. What can work there is prone positioning and high frequency oscillatory ventilation. Remember, all this is from adults. There are no such guidelines for pediatrics. I'm just telling you what is it in adults. Yes, some of it would apply to us. When you have less than 30, evaluate the oxygenation, compliance, dead space ventilation. Oxygenation, compliance, dead space ventilation, which means we are looking at the PaO2, SaO2, the EtCO2, and the PaCO2, and of course all the hemodynamics. If the patient is improving, it is a high recruitment potential, we'll probably go on along this. If the patient does not improve by these four things that we have tried, possibly, then we say that this patient has very little recruitment potential. And then we will go on to inhaled nitric oxide, no response in few hours, consider steroids, if no improvement, consider ECMO. This is the protocol that has been published and recommended. And if, of course, if the patient has shown good recruitment, continue same. So the questions that we will ask ourselves and try to answer are, what is this recruitment maneuvers in ARDS? What is it? What is the physiological basis for it? Does RM actually recruit lung? Do we have proof? Do we have evidence? Does it improve the oxygenation as it's claimed? Does it reduce the ventilator-induced lung injury in all its form or in some of its forms? Does RM reduce the mortality? The crucial question, does it actually reduce the mortality, the final outcome? Is it safe? Does it lead to complications? Lots of them, a few of them, or how severe they are, how frequent they are. How to choose a patient to use RM, which patient will benefit, which will not. What should be the method of application of this recruitment maneuver, and what would be a method to maintain that recruitment after you have achieved a recruitment. A long list, but let's try to cover it. This recruitment maneuver refers to a dynamic process of opening previously collapsed lungs units by increasing the transpulmonary pressure. Transpulmonary pressure is PIP minus PEEP or something like that in a positively ventilated child. Why do we want to recruit the lungs? Positive pressure ventilation generates tension at the boundaries between aerated and the non-aerated parts of the lung, which will be very frequent, these areas and those areas in ARDS. And repeated high pressure ventilation may cause damaging shearing forces at these junctional. So if there is a group of alveoli which are being ventilated well, the other group not being ventilated well, with each breath this opens up, this closes, this part moves very little. So with each time there is shear force between them, and that would be harmful. Another stress induced by positive pressure ventilation is the cyclic opening and closing of the alveoli in the presence of inadequate PEEP. If we had not applied enough PEEP, during inspiration, because of PIP, this alveoli will open. But if I have not given enough PEEP, this has a tendency to collapse because of surfactant and all these problems in ARDS or, for example, in HMD also. So once it closes and opens with each breath, you can imagine what will happen. Reduced tidal volumes are probably responsible for increasing the alveolar de-recruitment. If we are using low tidal volumes, which we are always told 6 ml per kg or even less, go to 5 or even 4, which means with each breath we are not ventilating them hard enough. So there will be some areas which are, because of the disease process, not inflated by this low pressure, this low volume translates into low pressure also. In general, lung units can be kept open by airway pressure that are lower than those required to open them. To open them, there is the opening pressure that is required. But once it is open, it can remain open at a lower pressure. Just as to blow a balloon which is totally collapsed, for the first time you blow, you have to really blow hard into it. Once it is half blown, to blow it a little more, a little less, hardly any pressure is required, hardly any force is required by you. Same thing happens there. So in general, lung units can be kept open by airway pressure that are lower than those required to open them, leading to the concept of recruitment using periodic higher pressure maneuvers with moderate levels of PEEP to maintain that alveolar patency. So you apply a lot of force to open it. After that, don't allow it to come back to 0 or even 4 or 5. Maintain a higher PEEP so that it doesn't collapse completely. That is all recruitment and maintaining the recruitment. Stuck. Help me. Not moving. The open lung is ventilated on the expiratory limb of the pressure volume curve rather than the underinflated lung on the inspiratory portion of the curve. This is something which we have heard again and again. Let me explain what it means. This has been shown that if you have started increasing the pressure on this side, and this is the volume here, as you go on increasing pressure, more and more areas start opening up. You can see the air coming into it, more air, more air, more air. Now for the same kind of pressure, if this is during inspiration and that is the expiration, this is the hysteresis in between, then for the same pressure here during inspiration, this much was the air in the lungs and the rest posteriorly and dependent parts are collapsed. For the same pressure, you look at this on the expiratory wing, much more air is there. Same thing applies here. These two are comparable pressures. Look at so much air there and so little air. So when you are ventilating the lung after opening on the expiratory wing, for the same amount of pressure, you are getting much more volume. That is what has been shown by these dynamic. So this is what we all want to do. We want to ventilate in this area which is called the safe zone. We want to ventilate here. This is the lower inflection point, this is the higher inflection point, and somewhere in between the two, it is the safest area, because here there will be too many collapses. Each time you will be opening and closing, and here you are causing hyperinflation. It's not only these openings and closing and not only these volumes that we are looking at when we are in the safe area. When you are around the FRC, even the pulmonary arterial pressures are the minimum. When you are below the FRC or higher than the FRC, the pulmonary arterial pressures also get worse. So both the points have to be taken into consideration. Because of the increased atelectasis, they may appear to be more effective in situations in which a low PEEP is being used in recruitment maneuvers. When more atelectasis is there because of lesser PEEP and you apply a recruitment maneuver, obviously you get a more advantage. If you are already on the higher pressures, on the higher PEEPs, there's not much that recruitment maneuver may be able to do. Doesn't apply every single time, but in general, yes. Recruitment strategies may prevent microvascular leak and right ventricular dysfunction. This has been proven in rats. Probably does apply to humans. Then what are the recruitments? What are the determinants of recruitment? I have mentioned a few. Let's go through them once again. If you want to recruit lung, you have to look at what type of ARDS it is. What is the severity of ARDS when we are trying this recruitment maneuver? How much time this ARDS has already persisted, and that means whether it's just the exudation phase or it has gone into a later phase, and what are the mechanics of the chest wall. Chest wall is also important. Patients who are ventilated in the supine position benefit more than when they are in the prone position. If you are already prone, that itself is a recruitment maneuver, that's different. But if the patient has been prone and now you are going to apply a recruitment maneuver of the type that I am describing, then the results will be somewhat less because some recruitment has already occurred. Than when in the prone, which is probably related to the presence of more dependent collapsed lung in the supine position. Extrapulmonary ARDS benefits more because of homogeneous distribution of pathology. A patient who has a let's say aspiration pneumonia, now gone into ARDS. Half the lung is aspirated, half the lung is having effects of ARDS. So you have non-uniform pathology. You cannot expect same good results. Higher response rate is noted in patients early in their disease course, probably the exudative phase, than later, which is probably the fibroproliferative stage. Patients with pneumonia have limited recruitable lung, so worse outcomes with recruitment. Patients with poor chest wall compliance are less likely to benefit from recruitment maneuvers than those with compliant chest walls. So this is also an important issue in some of the patients, the younger ones who have, let's say, hypocalcemia, rickets, and all kinds of deformed chests, or they were very premature and not really grown up well. So those chests can become a problem. Prone position, the pressure in the prone position, the pressure required to achieve recruitment is lower than the effect is, and the effect is more sustained. Although it is not easy to, you may not get a lot of benefit, but you may not have to apply a lot of pressure for this. The inspired oxygen fraction may affect the lung recruitment because of absorption at electricity situation where inspired oxygen fraction approaches 1. So recruitment effect may be rapidly lost in patients with ventilated 100% who are being ventilated 100% oxygen because of absorption at electrolysis. Which means if you can bring down the FiO2 quickly after recruitment or probably before that, the recruitment will last longer. So we've given you some basis for recruitment and what are the kinds of patients who are likely to benefit. Now let's see how exactly to do it. A sustained high pressure inflation uses pressure from 35 to 50, more often 40 is the most common pressure use, for a duration of 20 to 40 seconds. Again, 40 for 40 seconds is what has been tried in several adult studies. It is important to ensure that the pressure support level is set to 0 to avoid additional pressure increases. If you have not set the pressure support level to 0, then that will add up. So remember to do this. Additional short-acting sedation may be useful at this stage when you're going to try. Make sure if the patient is already sedated paralyzed nicely, very good. If the patient was otherwise just on the borderline, probably some extra bolus of sedation or a purge will be required before you go through this procedure, because it is of discomfort to the child, to the patient. Intermittent sighs have been demonstrated to achieve recruitment. Not very popular, so I'll jump. Extended sighs also have been used, but this is the second method. First one was this that I described, and the second that is commonly used. Pressure control of just 15 centimeter PIP with a PEEP of up to 25 to 30, which means a total of 40 to 45, the two added together, is given for as long as 2 minutes. And after that, you bring down the PEEP to this level and then try to come down, down, down to a level till the patient starts showing deterioration is compliance, oxygenation, or such matters. And then probably what you would do is bring up the PEEP to maybe +2 from where the deterioration occurred and stay there. That would be another method of recruiting the lung. It results in improved oxygenation with a reduction in partial carbon dioxide tension, and when both these things are occurring, then we say lung recruitment has occurred. When more alveoli open, patient will be able to exhale out more CO2, quickly his PaO2 will fall, and that is how we will say that recruitment has occurred. Pressure effects may redirect blood flow and improve oxygenation, but in the absence of recruitment, even when there is no recruitment, but this will not be associated with reduced partial pressure of carbon dioxide in the blood. So if you get only PaO2 benefit, you may not have really recruited lung. What you may have achieved is redirecting the blood flow. If you have achieved both these things, chances are you have recruited lung. And of course, there are many more methods to know that you have recruited. How frequently should we do it? The frequency with which recruitment maneuvers must be applied is not known. However, this probably depends on the underlying disease, the level of PEEP, the procedures such as endotracheal suctioning, and so on. Who needs recruitment and when? Atelectasis is related to general anesthesia during positive pressure ventilation, following suctioning, or in other conditions that produce hypoxemia, including heart failure, ARDS, and so on. You would need recruitment. So where does it fit? Recruitment maneuver in this whole strategy. Lung recruitment, volume recruitment procedures have a role to play as an adjunct to pressure-limited ventilatory strategies. Second, lung recruitment maneuvers may aid in the choice of appropriate PEEP. I told you we set a PEEP of 20-25, something like that, plus add a 15 of PIP. We have recruited the lung. Now we maintain this PEEP at, let's say, 20-24, bring it down to by 2-2-2, till you, every 2-3 minutes, till you find that you are losing what you had gained. Now go back +2 and stay there. So that means you can work out what is the best PEEP for your patient. It can identify patients with extensive recruitable lung and those with a low recruitment potential. So we know how aggressive we should be. Next time that we are going to suction, next time we are going to, if we are not achieved very much in 1-2, next time we are going to suction, detach, or for some reason, then going very aggressive with your recruitment maneuver may just harm the patient. In a patient with clear response to recruitment maneuver, the PEEP level required to prevent recruitment can be assessed by the decrement, which I have told you how. Third, lung recruitment maneuvers may be used to recruit the lung after interventions associated with recruitment, including ventilator disconnects and endotracheal suction. So these are the advantages of doing recruitment. One, you have achieved something. Next, you know what to do next time. And third, you know what not to do. What would be the adverse effects? And that's what we come to. Reduction in venous return. Cardiac output may be impaired, producing hypotension, a complication that appears to be more common in those with poor chest wall compliance and limited oxygenation response from recruitment. Those who recruit will have alveoli inflating, so pressure will be distributed. Probably harm on the return, venous return will be less. Those who do not recruit and yet we apply pressure, obviously will have more hypotensions and high worsenings. This can decrease the cerebral perfusion pressure, and there is at least in one of the trials, one patient's ICP which was being monitored shot up for a short while. Of course, it can lead to barotrauma. We are applying pressure. Bacterial translocation probably also occurs during recruitment maneuvers. So with this, we have listed what are the methods. Now, I'm supposed to review the literature. This is one, Fan et al. Have done a meta-analysis in 2008. These are adult studies. And they conclude, this as the conclusion, given the uncertain benefit of transient oxygenation improvement in patients with ALI and lack of information on their influence on clinical outcome, the routine use of RMs cannot be recommended or discouraged at this time. It cannot be recommended, nor can it be discouraged. So you got to individualize. They say that RMs should be considered for use on an individualized basis in patients with ALI who have life-threatening hypoxemia. So life-threatening hypoxemia, but don't delay it too much. Same authors, patients with lower PaO2, FiO2 improve more. So don't wait too long either. Lower compliance pre-recruitment maneuver improve less. So if the compliance was very poor, you are already measured it. It has already been displayed on your computerized ventilators. So this is the one where you know that it may not work. Be extra careful. These are the randomized controlled trials of recruitment maneuvers that they went through. These are the 4 major ones, 57, 28, 30, and 366 patients. They were analyzed, and this is how frequently they did it: every other day, twice daily, once daily, up to 4 times daily. And I've already told you what their conclusions were. Of importance is that in these trials, they saw that hypotension occurred quite commonly. 114 of these patients had hypotension. Of course, they were ready for it, they anticipated it, they were able to come out of it safely, and that is why there are no mortalities kind of things directly associated with this. Overall mortality in this study was 38%. In another trial, it was seen the risk of recruitment maneuver, another analysis, 22% within one trial had shown some form of problem. Hypotension, again, most common. Arrhythmias, probably we don't see it often in children. I'm not talking of any published data from my side, but probably we see it less often. Desaturations and barotrauma, again, not too common. This is what we always think will be the biggest problem. Probably not true. This is the biggest problem. And those of you who have done recruitment maneuvers on the bedside would vouch, yes, this is true. This is a study which is currently going on in Boston. They're targeting volumes which will be near FRC. They are using methods of PV curves to make out whether recruitment has occurred or not, and what is the ingoing and what is the outcoming and all that. They are also using multiple breath nitrogen washout techniques, which is supposed to be gold standard. They are also using electrical impedance tomography. They are also using exhaled breath condensate pH. Sorry, probably they are not using, this is also one which can be used. So this is what their protocol is. Their primary outcome is PaO2 plus PaCO2 of more than 400 or higher, something I just can't believe, because kind of patients that we try to recruit, their PaO2s are in the range of 100 or less. Probably we do it too late. And even if we recruit very well, probably we'll reach 200 plus, not 400. So probably it's a different kind of patient and different kind of design they're talking about. Secondary outcome is safety, air leak or cardiac compromise. Within 4 hours, this is within 2 hours. They want to enroll just 20 patients starting from 2008 and ending 2011 December. The recruitment should have finished by now. This is what their website says. What they are doing for recruitment is 3 types of interventions are being done. 6 ml per kg tidal volume at an appropriate rate and currently prescribed PP levels. This is what is already going on. Now the 6 ml per kg tidal volumes at an appropriate following 40 centimeter pressure for 40 seconds. This is the maneuver they are using, and returning to P-flex plus 2. This is what we have already described how to do it. The other thing is PEEP titration starting at 15 centimeter and increasing in 5 centimeter CO2, increase until the PaCO2 and PCO2 together is 400 or higher. So this is how they are going about recruiting lungs in these 20 patients. And results are of course not due yet. What about other studies? In pediatrics ALI, there's a study which is published in November 4, 2010 PCCM, 21 patients, incremental PEEP use for RM, and main outcome was PaO2, FiO2, PaCO2, nothing much except this improved, but PaCO2 did not improve. Adverse events, PaCO2 worsened in 3 patients. There's a study from Brazil, just abstract. I could not get whether this 4 was the correct number. It was spelled as FOYR. I don't know whether it's printing error or what. And they also they are not talked about adverse events. They say the PaO2, FiO2 improved. PO-SOD exchange also improved in their patients. There's a study in intensive care medicine, 32 patients who underwent 93 recruitment maneuvers, and then sustained inflation of 40 centimeters was used, and SaO2 remained same. FiO2 decreased by just 6%, and in 9 of these 93 RMs, it had to be aborted because patient started showing hypotension and so on. There are some other studies. Now these studies are in normal lungs, done by anesthetists when they were anesthetizing their patient for, let's say, another totally unrelated surgery or something. And in these also, they showed that compliance improved, MRI or CT scans showed higher lung volumes, and these other parameters also, and expiratory volumes also improved. So, but these are all in normal lungs. I do not know how much they would apply to conditions that we see in the PICU, the kind of ARDS. There's an adult study also, the famous study in which again 40-40 was used, and their result is fewer episodes of refractory hypoxemia occurred. Fewer deaths associated with refractory hypoxemia occurred in their group, but overall 28-day mortality was same in the 2 groups. So what are recommendations? Consider early, for RM, consider early if T-plat is less than 30 and hypoxemia is severe. It is contraindicated in shock, pneumothorax, or a very, very focal disease that you already know. Prepare the patient with adequate volume, adequate sedation to prevent asynchrony. After the RM, set the PEEP 5 to 10 centimeters above the previous PEEP to keep the lung open. Assess immediately after 6 and 12 hours. If hypotension has worsened, hypoxemia develops, abort the PM. If dead space ventilation increases, suggests over-distension, reduce the PEEP. There's a Cochrane review also which gives a similar thing. There is no evidence to make conclusions on whether recruitment maneuvers reduce mortality or length of ventilation in patients with LI or ARDS. Current status I have already told you. And this is the last slide which says strategies for maintaining the recruitment. You have recruited, you have succeeded, then what do? There are 2 approaches. One is open lung approach. Keep the PEEP set at 2 centimeters above the P-flex, which I have told you how to reach. There are studies to support that. Decremental PEEP titration is after the RM PEEP set at 20 to 26, decrease in steps till there is a fall of PA2 by 10% or PA2 plus PaCO2 falls less than 380, then you go back till it increases above 400. Then PEEP is increased by 2 centimeters. This is called the optimal PEEP. So two methods of keeping the lung open which you have already opened. Thank you.